slide, and I am sure that by now you have looked at all of the program, and you can see the 8 exciting lectures that we have planned for this masterclass. And we have also got quite some exciting speakers to be able to do justice to the topics that we propose to present at this masterclass. It's also expected that from this masterclass, depending on the uptake and how people benefit from it, we would then go on to transition to other programs that would help in promoting the knowledge of this technique, cardiac MRI, including its utility and interpretation. So we've got multiple speakers as part of the faculty who will deal with different aspects of the curriculum as we go through the 8 weeks. And there are a couple of housekeeping points that I need to make before we start. Here's a list of all of the lectures that we propose to do within the next 8 weeks. And the speakers as well are also included on there. In terms of housekeeping, we would normally expect you to complete a course evaluation at the end. So at the end of this session, we would expect you to scan the QR code and complete a course evaluation form. It's a very short form of about 5 or 6 questions, just to give us a sense of what you do and where you're at with the cardiac MRI technique, whether you're a beginner, like most of us are, or you are somebody who's experienced within the technique in the African setting. We would like to know, and we would also like to get some feedback about the lecture that you've listened to. So the way it's going to run, we're going to have our lecturer for today do a 45-minute lecture, and it will be followed by a short question and answer session. And that question and answer session would run for about 15 to 20 minutes. We will take your questions from the Q&A box. So there'll be a Q&A box that you can use to post your questions, or you can also do that on the Zoom chat, which you have, and we'll collate those questions. And at the end of those 45 minutes, our speaker will do justice to those questions. And if we run out of time and there are some questions that need to be carried over, we will try to address them at subsequent lectures in the next 8 weeks. There is the course evaluation, which I want to remind you of. Once you scan the barcode and complete the course evaluation, that would help us know how the lecture has been received. We will give an attendance certificate at the end of the 8 weeks. And it's expected that you would attend at least 80% of the lectures. That's 6 out of the 8 lectures in order to be able to get the attendance certificate. So that's as far as it goes with the housekeeping. So it's my pleasure to introduce to you our first lecturer, who's going to take us through the topic of course 1. And the lecturer is Dr. Uzamaka Chinekwu Ofong. She's a UK-trained heart failure and cardiomyopathy cardiologist. She's level 2 accredited in echocardiography, cardiovascular CT, and cardiovascular MRI. She's currently undertaking an advanced cardiovascular imaging fellowship at the Houston Methodist DeBakey Heart and Vascular Center Institute in Houston, Texas. So it's an honor to have her here to speak to us on this topic. She is very experienced in the field, and it's my belief that she would be able to do justice to the topic and take your questions at the end. So I'll stop sharing my slides and hand over to Dr. Ofong.
Hi, good evening, everybody. Thank you for attending. Just, can we see my slides now? Hello. Right. Okay. Excellent. Excellent. Right. Okay. Good evening, everyone. Thank you, Dr. Anna CK, for your kind introduction. So we're going to sort of start off our masterclass with an introduction to the entire modality, why the circumstances in which we prefer it to, the other available cardiovascular imaging modalities like transthoracic echocardiography or cardiovascular CT. We'll sort of discuss the strengths of cardiac MRI and whistle stop talk on the different indications. Unfortunately, no cardiac MRI talk starts without cardiac MRI physics because, the entire science and its advancement is pivots on physics. So I think one of the big strengths of cardiac MRI is that it fuses the unequivocal strength of magnetic resonance imaging with cardiac synchronization and fast breath hold imaging. Essentially, the ability to image body parts with magnets was an advancement in the whole world of imaging and radiography. However, what was the next challenge was that I'll just look through the charts. Right. I think everyone's just confirmed that they can hear me. What was the challenge with imaging hearts is that we're trying to get clear, crisp pictures and in a lot of circumstances, still pictures of an eternally dynamic structure called the cardiovascular system. And therefore, we would have to work on the strengths of the modality plus, our knowledge of a cardiac cycle, diastole and systole to try to get a phase, a spell where we can get the pictures we want to give us the information we require. The need for breath hold is also unequivocal because essentially we have so many moving parts in the body. So we've got the heart moving and we've got the respiratory system moving. And whilst we cannot necessarily stop the heart, but we've got the long diastole phase as some time that we can, get the heart to be somewhat still. But we don't really have such a phase in respiratory cycle, and therefore we can just tell the patient to hold their breath. Now, it means that whatever sequence or protocol we develop for scanning patients and scanning hearts, we would have to make sure that whatever we want to achieve can be achieved within one breath hold for an average adult, not an athlete. Otherwise, patients will just take a big gulp of air in the middle of it all and you're back to square one. Now, magnetic resonance imaging sort of relies on the intrinsic properties of biological tissues within a strong magnetic field. So we've got the Earth's gravitational forces. The Earth also has its magnetic forces. Now, structures in the body, naturally occurring substances and atoms actually are paramagnetic and magnetic. MR imaging actually pivots on that tendency to then get clear pictures of the body. Now we know that, if we go all the way back to sort of high school physics and chemistry, atoms which have a lone proton or a lone, proton in their outermost shell have the demonstrate greater magnetic properties. So you have things like hydrogen, sodium, carbon 13, phosphorus, and they have that lone atom, which means that you can manipulate what that lone proton in their outermost shell does. And with it, you can then distort to your advantage the behavior of the entire molecule. In the human body, because there's a lot of water, there's a lot of hydrogen nuclei, because water is a bit of oxygen and, the hydrogen atoms. So that abundance of hydrogen in the body means that we can manipulate it to our advantage. Now, that outermost atom has a spin, which means that it sort of rocks back and forth. And when you place it in a strong magnetic field, you're better able to see that rocking back and forth. And just like everything in cardiovascular imaging is all about emphasizing signal, reducing noise, so you have clearer pictures, that rocking back and forth can create a signal when you have the right electronic devices to receive it, which is where like our RF transmitter and receiver coils come in. So essentially, when you place a human, any biological matter, be it human or animal, in a strong magnetic field, the overall field intensity exerted by the magnets, and we'll go over some pictures and cartoons to better explain this, because for every MRI course I've attended, this is usually the crunch point. But we just need a bit of understanding to go through the rest of it. Now, when we are in a strong magnetic field, there's a field intensity that's proportional to the strength of the magnets, and that's what we refer to as B null. So when you then place this a patient into the field, it then aligns anything that is magnetic, just like, when we have a bar magnet and you have a material that is magnetic, North Pole will attract the opposite pole and vice versa. So essentially, whatever is magnetic will move towards the magnet. Now, we've already spoken that the abundant hydrogen nuclei is essentially functioning as a magnetic material. So it moves in the direction of the overall field intensity, and eventually these atoms all align. Some will be aligned in the direction of the field, and some will be aligned in the opposite direction. Now, for as long as the overall field intensity is strong enough, you have a bit more atoms, aligned in alignment with the field rather than opposite alignment. And it's actually those ones in alignment that you manipulate for all your imaging sequences. And then some research in it basically says that you have about 7 per million extra hydrogen atoms aligned with the field than opposite the field. And it's actually that 7 that you're moving around and turning all around to generate your sequences. So we'll go over to a picture that basically tells the story. So this basically is your MRI system. I hope we can see my cursor. So essentially, this is your standard MRI scanner, and this is your magnet within the bore, and this is the patient's table. Now, within this bore is that overall field intensity B null, right? And when a patient is on this table, when a patient is on this table, you sort of have 3 coordinates. These are like our basic coordinates of science. So you have a z-axis, which is the length of the patient within the imaging field. You have your y-axis, which is sort of bottom to top, and you have your x-axis, which is the patient's width. Now, eventually, when they are within the field, how you manipulate your magnet to get images will actually depend on this axis. So within this magnet, so that's now image A. So we now have a patient on the table within the bore. You have sort of 3 magnetic systems. You have the main magnet coils that are within the bore, and they exert the field intensity, and they are static. They don't move in principle. Then you have your gradient coils, your X, Y, and Z gradient coils for those X, Y, and Z axes. Now, these can generate, so they are not permanently sort of on, and you switch it on and off depending on what your overall imaging destination is. They then generate a magnetic field that is dynamic, that oscillates, aligned with the axis in the direction of, aligned with the field in the direction of your axis. So, if you switch on the Y, it's going up. If you switch on the X, it's going this. If you switch on the Z, it's going along the height of the patient. And then you have further the closest magnetic system to the patient is this receiver, the RF transmitter coil. It's called the integral RF transmitter in this graphic. So that's this one that's closest to the patient. And that's, obviously has the greatest impact on the patient's hydrogen atoms because it's very close. And that also generates the fields that the receiver coils that are literally placed on top of the patient themselves now receive. So essentially, a manipulation of the overall field intensity with the gradient coils that you can switch on and off, and the RF transmitter coils that you can switch on and off, essentially now makes those hydrogen atoms to rock in one direction or the other, generate a signal that the receiver coils then receive. And eventually you go through, the mathematical process and then, generate your images. So I think there was a few other things I was going to say, which is that essentially when when the hydrogen atoms are known to rock precess, that's the precession. They're known to rock sort of back and forth at a certain frequency. And for every of these biological atoms that we had discussed, so that's hydrogen, carbon, carbon-13 or phosphorus, we know exactly what their behavior in a certain magnetic field would be. Now, our ability to calculate the frequency with which they rock forth is given by the Lamour equation, which basically, I think it's somewhere here. Well, it comes up in the cartoon. Well, it's given by the Lamour equation, which basically tells us that precession frequency is a function of the field intensity, which is the strength of the magnet, and it's a constant called a gyromagnetic ratio. So we can predict the frequency at which it oscillates. And obviously, as with every, like high school physics again, as with every material that oscillates or vibrates. Basically, if you superimpose a field or a sound at the same frequency, then you basically trigger you trigger harmony essentially. So if you direct a pulse of magnetic output at that frequency, then you get them to rock at your known frequency, and therefore you can basically control their behavior and get them to function at a time and get them to stop functioning at a time because of your knowledge of their behavior in that magnetic field. So essentially, this is like, this basically goes through how we generate basic MR sequences. So let's imagine that there's a patient in here, right? Head around the head of the arrow Z and legs here. Remember, we said that this is the Z-axis. The X-axis is sort of, their width back and forth, and then the Y-axis is top to down. Now, when they align, when the patient goes in there and they're just under the influence of the magnetic bore, and the big magnetic field. So that magnetic field is basically what gives our MR systems their classifications, where we have 0.5 Tesla, 1.5 Tesla, 3, 5, 7. Generally, in clinical imaging, it's generally 1.5 Tesla magnets that we use, and in cardiovascular imaging more so. There is, 5 and 7s are used in research, because obviously the stronger the magnetic field, the more the pull on the hydrogen atoms, and therefore stronger image intensity. Now, just for reference and analogy, 1 Tesla is about 20,000 times the Earth's magnetic pull. So these are very, very strong magnets. And, that comes to bear when we discuss things like MRI safety and all of that, because they have very strong magnetic fields. And if you brought a magnetic material in their presence, they will behave to show you that. So when we bring a patient into the field and they're laying on that table, or most of those, their own intrinsic magnetism will be aligned along the axis of the magnet, which is along the Z-axis. So they will be well aligned. Now, if you then apply a pulse, remember from those integral RF transmitter coils, because we know their behavior and we know the angles with which we can flip the direction of their alignment, we can apply an RF pulse at a known angle, and essentially we then split what was that person's intrinsic magnetism M null into 2 components, where you then have some magnetism along the Z-axis and some magnetism along the XY axis. Now, if you apply an RF pulse at 90 degrees, you basically flip everything from 0 to 90, right? Where all your magnetism is now along the XY axis, because you've basically flipped it from here all the way down. Now, once you remove this pulse, the atoms will behave in their natural characteristic, which is to try to align back to the bore and the main magnetic intensity of the field, which means that, let's take, for example, image B, when you have some in MZ and MXY, if you let go, some will start coming back all the way to Z, and the XY will start losing that, because remember, their natural behavior is to be aligned along Z. So the natural behavior is for MZ to be maximal and MXY to be minimal. Now, if we're able to flip it all the way at 90 degrees, we then generate, because we want to, a situation where all the magnetism within the body is at MXY. So all our M0 has become MXY in transverse, and we no longer have any longitudinal magnetization, which used to be MC. If we give it some time, they will process back to their natural behavior. However, that time, for as long as they are sort of out of their phase, when they're coming back, they actually elicit a signal, and then we can transform with all the supercomputers backing this up. We can then transform that into the image that comes up on the screen. So I just wanted to read what this said because it sort of adds more insight to it. So the maximal detectable signal amplitude occurs when M null lies exactly in the XY axis, when you have 100% transverse magnetization, but no M0. And that's at a 90-degree flip angle. And we generally call this a saturation pulse, because that way you basically get everything to behave as you want. And then if you then applied a refocusing pulse, so remember, your pulses change their direction. So if they were all aligned in this 90-degree angle, and then you apply a 180-degree force, it basically flips them all the way to here. They also generate a stronger signal that you can then pick up. And then you can then manipulate that behavior to, either let them come back to their natural, because the time it takes them to come back gives us some information. And also, as they're coming back, you're watching how quickly does M0 come back? How quickly do we lose all of MXY? And all of that gives us actually integral information. And the fun fact is that different tissues behave differently. So a healthy muscle will have a different time for all of that magnetization to be lost and for it to come back to its natural behavior of M0 being in the Z-axis. Simply because what these atoms do is to lose that magnetization to the surrounding tissues. So imagine if you have healthy myocardial muscle. Everything is healthy, so it's predictable. Versus if you had fibrosis, where you then have scar tissue in the muscle, as they are losing that, the speed at which they will lose their magnetization to the surrounding tissue is prolonged, because it's no longer similar tissue. You now have some scar and collagen rather than just muscle, and therefore your resulting T1 time will be prolonged. And that is, an integral piece of information when we characterize tissues in these patients. Yeah. So I think that's that for this. And this just gives us a bit more information on that. So basically, this now goes on to discuss the T1 relaxation and T2 relaxation processes. It's basically what I've said before, but like how it directly translates to image interpretation. So remember, everything was aligned when the patient went in. All their magnetization within their body, their heart, was aligned along the Z-axis. So you then apply that saturation pulse. I hope we can see my cursor. It's a bit tiny. But I'm discussing figure 3, the one that says T1 relaxation process. So we then apply where are we? We then apply that 90-degree flip angle pulse so that all the magnetization is now along the XY axis. And then we give it time to see when all the magnetization then recovers back to being along the Z-axis. Now, the time constant for which this tissue recovers 63% of its MZ magnetization is what is called the T1 time. And like I said, the T1 time varies depending on the tissue. So T1 time for fats is shortest because, in fat molecules, you have the adipose cells and you have very non-dense tissue around it. So it's so easy for it to lose its magnetization to the surrounding tissue and just revert back to MC. Whereas muscle will be longer. And then when you then have muscle mixed with scar, it's even longer because it's longer for the muscle to yield of its intrinsic magnetization to the scar whilst it reverts back to MC. Now, T2 time is basically looking at it from a different perspective, because when we apply, so I'm now discussing figure 4, the second image. When we apply that 90-degree flip angle pulse, RF pulse, it flips all the magnetization all the atoms from being in the MZ position to MXY. But they do have intrinsic longitudinal magnetization as well as transverse, which is basically a precession. And we'll see a cartoon soon that shows it. So that's what these arrows are trying to show. So when you flip them, they're all aligned in a certain way, and they're all in phase. But once you take away the pulse, they start going back to their natural habitat. So they all start going out of phase. Some are pointing in this direction, some are pointing in that direction. And that time for them to lose like 63% of their phase and go just with 37% being in phase, but this is now transverse magnetization that we're concerned about. That time, the time it takes for it to lose all of its transverse magnetization to just 37% of its original value is the T2 time. Now, this number actually differs depending on tissue and also tissue health. And that's why, therefore, in some circumstances, it becomes the main workhorse of defining certain conditions like myocarditis. The T1, T2 times are pivotal and part of the diagnostic criteria in deciding when a patient has presented with myocarditis or not. So that's that for physics. It always gets a bit, you always get a study silence after because it's just a bit much. So we'll go on to some cartoons that help me describe it better. So essentially, before I switch it on, let's assume these are the atoms, right? And they're not yet in the magnetic field. So let's assume that this is their polar direction. And you can see this is pointing in this direction, this is pointing in the direction. We will then see what happens first when they are all aligned. And then when you then see them, I'll talk us through what happens essentially. So let's watch it play. So now they are aligned. I'll just let it play a few times before I describe what I'm trying to show. Excellent. I think that's that. So I think basically they started off just, in their own direction in life. And then they go into the magnetic field and they all sort of get aligned, pointing upwards. And then you apply an RF pulse that flips them all the way. And we'll see how the red head arrows all point downwards because this RF pulse has tipped the nuclei and they're all pointing downwards. Now that gives us off a signal. And then when we're waiting for them to come back, the time it takes them to come back in this direction is basically how much they recover their longitudinal relaxation. That is T1 time. And then the time it takes them from, losing all of their transverse magnetization and coming back into their natural habitat is, well, to 37% of the original is what gives us our T2 time. So there's another one, which is a YouTube link. So this would be a bit clunky to start, but I'll just play like the first 5 minutes of it because I think just understanding this helps us, and then the rest of it we will get through quickly. Oops. And we see this YouTube screen come up. We can't. Okay, fine. Okay, so I need to share that. I thought I was sharing my entire screen. I'll just share that, please. Where are we? Share. Can we see it now? We can. Excellent. So I'm just going to play, bear with me, but the first four plus minutes, it really helps. Can we hear her? Can we hear her, please? Great. And sugar, good body, and of course, good water.
a significant portion of consists of water. And it's just have the ability to go against the current. That sounds like a situation. Again, it's called.
Hello, can you hear me? Hello. Yes, you can. I'm really sorry that you guys couldn't hear it. So I will share the link. Yes, I'll certainly share the link just now. And can you hear me? Right. Okay. Apologies about that. It was just the cartoon approach to it meant that we would better understand what they are saying, and it also helps to, see it from a different perspective that's not intensely academic. But I'm sorry you couldn't hear them. Not quite sure why that happened, but I will just carry on. In principle, it was summarizing all I had said and trying to, but I thought the graphics helped because you can then see what transverse magnetization is and how it's different from longitudinal magnetization, which is just in alignment with the axis. But, for the sake of time, we'll just crack on. So, a few things to say is that obviously patient preparation, ideally we want a conscious patient so that they can hold their breath. We also want a patient that can obey instructions and not be sort of writhing around. And therefore you realize that patients who are either in respiratory distress or in a lot of pain or, in well-steeped heart failure may not be your ideal patient because they just can't. They are too unwell to. Now, gadolinium-based contrast agent has always been a topic for discussion about who gets it and who doesn't. The initial agents were sort of nephrotoxic, especially. The initial agents were nephrotoxic, especially, at EGFR less than 30, and it was a contraindication. But then they, with the expansion of MRI in different fields, there's now second and third generation GBCAs, which have better relaxivity, which means that you need less gadolinium to achieve the image contrast that you want to achieve. And, it's no longer a hard contraindication if you have those newer agents, plus that it's dialysable. So for patients in end-stage renal disease on hemodialysis, it is dialysable. Another sort of what used to be an absolute contraindication was patients with cardiac implanted devices, so pacemakers, defibrillators, even loop recorders. Now there's been a lot of sort of work and research on this, and now we can classify devices based on their MRI safety, whether they are safe, conditional, or entirely unsafe. A lot depends on not just the box itself, but also the leads, because, the older leads. So if someone has a pacemaker from 20 years ago, it's unlikely to be MRI safe. But there are resources online that you could check, but it's unlikely because 20 years ago, no one really made those provisions. But if people have a device from like a couple of years ago, they are likely to be MRI conditional. Now, MRI conditional means that it is safe when the conditions are met, which is that the pacemaker or defibrillator is set at a certain parameter, and that the magnets they are going into is of a certain strength. Like we discussed, there's very high field, very strong field intensities up to 7 Tesla. Now, the pacemaker and its leads will not behave the same way in a 7 Tesla magnet versus, in a 1.5 Tesla magnet. The other thing is that when patients have had a newly implanted device, they just cannot have an MRI scan for at least 6 weeks because you want things to be well embedded because they will still move a bit. But if they're well embedded in the, in the trabeculae and in the muscles, then they won't move substantially to be discernible. So that leads us quickly to MRI safety. Now, remember, it is a magnet. Everything magnetic and paramagnetic will be moved by the magnet. So once, around an MRI scanner, we normally see all of these stickers around the door. And whilst, we may remember big things like keys and oxygen tanks, the other things is things like, ID badges, bank cards, anything with a chip and pin will be deactivated in the presence of the magnet. And, we would always discuss MRI safety with, this was last July. So this was somewhere in New York. A man, this news file, a man accompanied his wife to have a musculoskeletal MRI scan. And at the end of the scan, the lady couldn't get up from the scanner. And the technologist unfortunately said, please come in and help us. Now, what the technologist forgot at that instance, and that's all about, that's the human mind. There's always a blind spot, which is why we have to adhere to processes meticulously. What the technologist forgot was that at the start of the scan, he had commented on the necklace the man had on and how heavy it was. And the man said, oh yeah, it's a 20-pound neck chain I use it for muscle training, strength training. So the man eagerly comes into the MR scanner to help his wife come off the scanner. And of course, he's pulled and slammed onto the scanner. Now, here's a bit of cardiovascular history, but even that is frightful. And long story short, he's stuck to it because nobody can pull him apart from the scanner. He's stuck to it for about an hour. He's terrified. He has lots of cardiac arrests during the ordeal. And unfortunately, he actually dies the following day. So these are substantial risks that we always have to bear in mind, whether we're setting up a service, whether we're involved in an existing service. The safety algorithms have to always be run through at intervals to make sure. And usually there's someone in charge for the system, like within the hospital, there's usually a protocol officer that looks over these. So this is just a few pictures of real life events. That's an oxygen tank within MRI. That's a wheelchair. That's a hospital bed and all that. And hospitals would have an MRI safe hospital bed and a non-MRI safe, which means that if a patient is really immobile and needs to be wheeled in, they have to be transferred to a hospital MRI safe bed. Now, this is a child who I think someone forgot a pulse oximeter. This is a 5-month-old baby, forgot a pulse oximeter on them, and they went in to have the scanner because the other risk from MRI is the bonds. And obviously, it's because, you can transmit the RF pulses through materials that can conduct electricity. So be it electrical substances, electrical material in contact with the patient or other things that can conduct. So for this child, unfortunately, it was a pulse oximeter that was connected when they had their scan, and it just conducted a lot of RF pulse to that arm and basically led to a degloving injury. So discussing, the strengths of cardiac MRI scanning is the fact that it has pretty much good spatial resolution, good temporal resolution, and fantastic contrast differentiation. So essentially, we have this is it comparing against other modalities in imaging. We have a spatial resolution of 1 to 2 millimeters when in plane, and then, 6 to 10 millimeters is our slice thickness when we take slices, which means that in plane, any structure that is thicker than 1 to 2 millimeters will be represented by more than 1 pixel, and therefore we can see it in detail. Also, its temporal resolution is 30 to 50 milliseconds, which, is basically a small section of the cardiac cycle. So the combination of really good spatial resolution and really good temporal resolution with that excellent contrast resolution means that we can then image a lot of things. However, if we have structures that are less than 1 to 2 millimeters, and we're now in less than that, then cardiac MRI may not be your best modality. And we're talking things like maybe endocarditis vegetations, looking at whether people have aortic root abscesses, because these are ridiculously subtle differences, and that's sort of where you have the strength of CT. But in things like, imaging volumes, the volume assessment of the heart cardiac MRI is your gold standard in assessing flows and shunts, which may be relevant in patients with congenital heart disease, where you're comparing pulmonary flow to systemic flow, what the difference is, and whether QPQS is more than 2, so that you refer them for intervention. Then cardiac MRI is your best bet. And this really leans on its ability to get the best assessment of volumes, and therefore you can categorically say that this is the end diastolic volume of the right ventricle versus left ventricle, and the difference is this, so that you can give your recommendation for the patients. So I think the next, we just summarize it in terms of the strengths of cardiac MRI are really in volume, function. It's coming into strain, but it's the gold standard for assessing volumes and function. Myocardial perfusion in the assessment of coronary artery disease and its impacts like ischemia. It's also a strong workforce, because we have the ability of seeing the muscle in great detail. We can also assess for perfusion as our contrast comes into the myocardium, and then we can see where the contrast comes in really late because the vessel is pinched, and you can see the difference. And we will sort of walk through a few examples. And we remember, like, our first session is a good summary, and then the subsequent sessions will go into great details of how we do it in each of these conditions. Right. So I think this just basically heightens it. It's the reference standard for volumes and function. It has the best inter and intra-observer variability because, it's cross-sectional imaging. The determination of where the heart is and all that is determined by the magnet. So even if the patient lays a different way the next time, it's still going to find the alignment. So we don't have the risk of foreshortening that we have with echocardiography. It's not operator dependent like echocardiography is, because you could actually foreshorten LV apex without knowing it. We don't have that problem. And we can't forget that cardiac MRI is absolutely no radiation cost. So it's almost at zero cost to the patient in terms of the cons of the procedure, because there is no radiation cost at all, and the contrast agents are largely safe in the majority of the population. So essentially, because it gets well-aligned views, so this just tells us like what a cine stack from cardiac MRI looks like. We get well-aligned 3-chamber, 4-chamber, 2-chamber views, and then with it, we then make slices to generate this short axis stacks. Now, the stacks are usually 6 to 8 millimeters thick with 1 millimeter gaps in between. And the gaps overlap so that you have a good representation of the LV from base to apex. And then you then apply these contours to define what the epicardium is in yellow. In the stack on the left is the left ventricle, and well, my left, I don't know how it renders on your screen, but the stack on the left is the left ventricle, stack on the right is the right ventricle. So the yellow contours define our epicardium, the blue contours define our endocardium, and with it, we can most accurately calculate volumes, but also it's very reproducible that next time it will be related to, we don't have widely divergent volumes. And even if you do it on another scanner, for as long as the angles have been well achieved so that you have long axis views of the left ventricle, then you would have good volumes. And that way we have excellent volumes of the right ventricle. Now, for everyone who's a cardiologist or anyone in imaging, you know that, the right ventricle, we don't really know how to assess it very well with echocardiography. There's surrogates of surrogates like TAP-C and, RVS prime, but we never really calculate RV volumes in echocardiography conventionally, but now we do, and you have very reliable volumes. So it's gold standard against which I know it compares directly with invasive measurements in the cath lab. So I think I've gone through this, and the importance of sort of discussing this, getting these volumes accurate is the fact that it actually defines who has what, whether a patient has heart failure with reduced ejection fraction or mildly reduced ejection fraction is actually a function of those volumes and the ejection fraction. So this is a snap from the ESC focused update on management of heart failure. And we can easily see that the definition of HFrEF is EF less than 40 or equals to 40%. And HFmrEF is 41 to 49, which means that we really have to be certain of what these volumes are. Otherwise, we also know that outcomes-wise, the management of HFpEF does not really work for HFmrEF. Management of HFrEF the management of mildly reduced ejection fraction is very different from management of reduced ejection fraction. Their risks are different. Their arrhythmic risks are different. Their sudden cardiac death risk is different. So as subtle as that number is, it has a huge impact on the patient outcomes, what they are offered, how we see them in the clinic, whether we think they are high risk or low risk. This is now sort of from the ESC guidance on management of valvular heart disease. And we can see that, this is not obstructing, but CMR is your recommended modality for chamber volumes and function, regurgitant fraction, because again, the management of valvular heart disease, what determines when we offer a patient with aortic regurgitation or mitral regurgitation intervention is actually a combination of their ejection fraction and their regurgitant fraction. Now, both of these are from volume assessments, and we know from, retrospective analysis of outcome data is that when we don't get it right, the patients fare badly, essentially. And this is from ESC guidelines on the management of ventricular arrhythmias and sudden cardiac death. And we can see that Again, CMR has a class 1 indication for any patient with ventricular arrhythmias or that we are assessing for sudden cardiac death because of all the information it gives us. Now, in this specific circumstance, it's no longer just about the volumes, it's also the tissue characterization. The presence of LGE and the proportion of LGE, which is late gadolinium enhancement on cardiac MRI, is directly related to risk of sudden cardiac death, outcomes, heart failure, etc. Now, late gadolinium enhancement is, a modality we will go into great detail when we discuss this, but essentially, it's that when we give these patients the gadolinium-based contrast agents, if they have scar within their myocardium, then it will hold on to the gadolinium. And then when we scan them, sort of usually 10 to 15 minutes, depends on center, but most people scan between 10 and 15 minutes after injection of contrast. Healthy myocardium, the gadolinium would have gone in and washed out, but unhealthy myocardium, which has expanded extracellular space or collagen within the muscle, will actually hold on to it. And these are areas of either diffuse interstitial fibrosis or absolute replacement of myocardium with scar. Now, those patients have worse outcomes, and it's proportional to how much late gadolinium enhancement and how much fibrosis they have. So these are pivotal measurements to actually extract from a patient. I realize we're almost stuck for time. Now, myocardial ischemia would always rank highly in any conversation in cardiology because 40% of cardiovascular disease is due to coronary artery disease, and cardiovascular diseases are the top reason why people die or are unwell since, in WHO records for the last 30 years, unbroken. So, this is from the ESC guideline on the management of chronic coronary syndromes, and essentially it's a stepwise algorithm on what to do. So when you assess a patient, at the end of the day, having taken their history, risk factors, all of that, at the end of the day, the question is, what is the probability that they do have coronary artery disease? If you think this probability is next to zero, do nothing. If you think they may have coronary artery disease but is not obstructive, then you can do an angiogram. But if you think they do have coronary artery disease and they have obstruction, therefore have ischemia, then, what do you do? Now, prior to MRI and all of that, what they would have done at this stage is go straight to invasive angiography. But we know that, once it's invasive, there are risks. But now we can categorically tick the box of do they have ischemia? How bad is their ischemia? By doing a stress perfusion CMR, which is entirely non-invasive. It's a 1-hour scan. We use almost the same things we do for a standard MRI scan, apart from the addition of a vasodilatory stress agent like regadenoson. And then we can then see you. And, there's a lot of data out there. We will show that in the subsequent sessions where you see where it matches entirely nicely the amount of ischemia that you see on your cardiac MRI stacks versus the ischemia that is proven in the cath lab and all of that. So then we have a reliable non-invasive test to give us answers that actually lead to interventions that prolong life. And this just tells us the different modalities we use in assessing cardiac MRI. Now, the perfusion map from the CMR is, very reliable, and it gives us the information we need. I think this is just a picture showing. So basically, we inject a contrast agent and then we start scanning as it starts perfusing the myocardium. And you want to see this myocardium go from black to light, which tells you it's been perfused. But you can see that the rest of the myocardium, which is, if you look at it like the face of a clock, the rest of the myocardium seems well perfused. There's some blackness here, but here there's also a lot of blackness. So this bit is not perfused. And remember, at the end of the day, whatever we give the patient through the face is going to get to this myocardium through the coronary arteries. And therefore, if we have coronary artery disease where it's pinched, then the perfusion will be delayed or not even happen. And we have this. So, for you to say that this is a positive perfusion test, it has to correlate with a non-coronary artery territory. And when we look at this, we can categorically say that this patient most likely has an RCA lesion because we can see that it correlates nicely. Now, this is what a late gadolinium enhancement image looks like. So you've given them the late gadolinium, you've given them the gadolinium, you've given time for it to wash out, and then you start taking your images. Now we can see that the rest of the myocardium here is nicely black. So the contrast has gone into it, it's gone out, it's in second pass perfusion. But for some reason, there is still white here, which is that contrast. It's hanging onto the muscle here because this is not just muscle. It has expanded extracellular space. It probably has some collagen scar. And this is in principle, what a subendocardial scar looks like because it's closest to the blood pool. It doesn't quite extend to the outer wall. So it's not a transmural scar to go through and through, but again, it's in the coronary territory, so this is most likely an ischemic scar. So you see, we can easily tell who has an ischemic scar, a non-ischemic scar, who has coronary artery disease, who doesn't, because there's lots of people with ejection fraction of 20% with CAD risk factors who actually have very clean coronary arteries because they have dilated cardiomyopathy. Now, it again is, impactful in the assessments of velocity and shunts. Now, because we have sort of the heart well before us in every view, we can basically put through plane views through any valve, below the valve, at the valve level, above the valve level, and we'll basically get the flow. Now, obviously, if we put through plane views through the aorta, we will get aortic flow, which on this graph on the left is denoted by AO. If we put through plane views through the pulmonary valve, we will get the pulmonary flow. And, the software that backs it up can then calculate aortic flow versus pulmonary flow. It gives us systemic cardiac output versus pulmonary cardiac output. And then you compare the two. Obviously, it should always be equal because what goes into the right comes back through the left. But in situations where you have a shunt, a VSD, or significant valvular regurgitation, then there'll be a difference. Now, once your conditions are met, i.e., if a patient doesn't have a valvular regurgitation, but has a difference, then if the valves are fine, but you have a difference, then they must have a shunt somewhere. If the valves are regurgitant and you have one regurgitant valve, then the difference in flow from right to left must be your regurgitant volume, and then you can calculate your regurgitant fraction from that. So it gives us, and this we couldn't categorically calculate from the other modalities because they were not gold standard. So previously we would do this with echocardiography, but everyone who's done an echo knows that there's no way to know who has good acoustic windows. The 21-year-old student from the university may have ribs that are stacked on each other and you can't see. The big BMI 40 lady who you think you won't get any picture from may have beautiful pictures, but they might get tired halfway through your scan by the time they're laying on their left, raising their arms. So this modality, the patient is just laying on their back and you're doing your stuff. All you have to do is, sometimes you give them earplugs if they want it. In some scanners, you can actually play the music they want, and they can, they just need to be barely awake to follow your breath hold. And you get all the pictures you want, data that is pivotal, completely pivotal in how you manage them, what happens to them, the diagnosis you give them. And, we have interesting cases where you think it's this, and then you do a scan and you're like, oh my God, it's not even that, it's this. And that's what we'll go into in the rest of the sessions. But, this is basically how we do the shunt assessment, compare the two, see the difference. For the patient on this example, QPQS is 2. So they have a shunt. 2 is usually the cutoff for intervention, for patients with shunt defects and all of that, and septal defects. Now, tissue characterization is the main workforce of cardiac MRI because no other modality is able to tell healthy tissue from unhealthy tissue just by a scan. No other modality. So when you have a patient with ejection fraction of 30%, so many things are possible. They may have had a catastrophic proximal LAD infarct and lost all of the anterior wall, and that's why the ejection fraction is low. They may have dilated cardiomyopathy. They may have cardiac sarcoidosis. They may have, burnt out amyloid that no one knew about. They may have so many things. And prior to MRI, what did we do? We managed them all as heart failure. Some got better, some didn't. We didn't know why. And that's why when you look at heart failure trial data from years ago, outcomes are so different. Yes, our medications are far superior, but also our ability to phenotype who has what is much stronger, because now we know that if a patient has DCM, this is what we do. If a patient has sarcoid, it's the biologic agents that they need. It's not really Entresto before the biologics. So it has just transformed the field of heart failure and the management of patients with myocardial diseases. We're going to touch on a bit of this because I'm well aware that it's now stepped beyond time. We've seen this picture before. It's just to highlight what late gadolinium enhancement does. So we can see it becomes really clear to see where the impact is, the limit of the impact, and now our software, the cardiac MRI reporting software, are now able to tell you what proportion of the LV myocardium is scar. Because remember, we've already done the contours when we were doing our CNS, the contours that I showed prior. So we know how much LV mass the patient has, and then we can easily calculate how much mass is overtaken by the scar process. And then it becomes a ratio and a fraction. But then outcome data has proven that patients with scar burden more than 15% have a very high risk of sudden cardiac death, largely in the non-ischemic cardiomyopathy world, but also in the ischemic cardiomyopathy world. So it changes what you do. It also comes to bear in some guidelines of some specific genetic cardiomyopathies where the presence of scar, even if they don't have very low EF, gives them an ICD, even if their EF is not less than 40%, because their risks are high due to the genetic cardiomyopathy they have with the superimposed scar burden. Now, myocarditis is one of the strongest success stories of cardiac MR imaging. Professor Frederick, who speak later during our masterclass, is one of the pillars of cardiac MRI generally, but also of this field. Now, the diagnosis of myocarditis. Now, myocarditis would present with a bit of chest pain, a bit of a trough-like, abnormal EKG, and an unwell patient. Quite some time, they would also have a viral prodrome with it. Now, if you did an echo, you may just see an LV that is not entirely normal, but it's not terrible. Now, what we now know is that 1 in 3 of patients who have myocarditis actually have a genetic mutant, and actually a lot of genetic cardiomyopathies, their first presentation is with myocarditis. Now, if we're able to completely diagnose who has myocarditis, then we actually see the full extent of their myocardial damage, because with cardiac MRI, we can actually calculate how much myocardial edema they have, because T2 weighted images and T2 mapping basically looks out for water, how much water is in the myocardium. So we can tell which wall is involved. We can see how much edema is there. We can also see if they even have a scarring process, which suggests that they've had injury before and tried to heal it. We can even see if the pericardium has been affected, because we can see the pericardium very well. As someone who reports CTs and MRIs, I can tell you the startling difference between how clearly we see the pericardium, especially in pericardial inflammation on echo versus CT versus MRI. On echo, it has to be really advanced before you can categorically say the pericardium is bright. And, sometimes it's when people already have constrictive features. But, on MRI, we see quite well. And on CT, we do, see quite well. But the advantage in MRI is that you can then add on this information layer upon layer to then actually make a distinct diagnosis, which completely alters the course of the patient. So we no longer manage this person as a person with the flu, with an unexplained subtle trop rise, but we actually give them the appropriate diagnosis of myocarditis, the appropriate follow-up, whether it includes actually having further follow-up cardiac MRI in the next couple of months, and also whether you actually offer them genetic testing, because 1 in 3 is high. 30% of the patients who present with myocarditis actually have a genetic mutant, and this has been demonstrated across age groups. Initially, we thought it was just young people, but there was a paper from a couple of weeks ago which demonstrated that even in the geriatric population, this proportion remained about the same. Now, cardiac amyloidosis and infiltrative cardiomyopathies is another one. Now, when patients had left ventricular hypertrophy on echocardiography, we'll just say they've got left ventricular hypertrophy, and sometimes they are even labeled to have hypertrophic cardiomyopathy. After all, it's hypertrophic and the muscle is abnormal. which is not really the right way to, the right nomenclature, because hypertrophic cardiomyopathy is a distinct disease entity. Now we know that patients with hypertrophic hearts could have the hypertrophic cardiomyopathy, that is a genetic disease. They could also have cardiac amyloidosis. They may have Fabry's disease. Now, the management of these conditions are widely disparate. And we wouldn't offer them the right care if we don't actually completely characterize who has what. It also has far-reaching implications for things like Fabry's disease, that is an X-linked disorder that would always be passed on to the next generation for as long as the X chromosome is passing on. And we know that Fabry's disease is a multisystemic disorder. Patients have renal failure from it. Patients have skin conditions. Patients have, heart disease, myocardial disease, and burnt out heart failure early in life. So it actually is quite important, especially, in climes where you then have access to the replacement therapy. You then realize that differentiating which 21-year-old has hypertrophic cardiomyopathy versus amyloid, though rare, or Fabry's disease changes their outcomes a lot. Now we have medications that can treat hypertrophic cardiomyopathy with obstruction, mavacamten. So you give that to the right patient, because LVOT obstruction can happen in any hypertrophic condition, including hypertensive heart disease, including aortic stenosis. So having LVOT obstruction does not mean they have hypertrophic, HOCM. Now, you could also, if a patient has Fabry's disease and they have access to replacement alpha-gal therapy, then knowing that on time helps. And to be honest, a standard MRI scanner with the clinician knowing what the question is and getting the right sequences on actually answers these questions non-invasively. So we now have situations where your cardiac MRI is as effective as myocardial biopsy in some circumstances. I must be coming to an end. Yes, apologies, I'm 7 minutes off, but we're nearly at the end. So here we are, and basically this is an expert consensus statement from a few years ago by a few, pillars of the field, and basically showing us in a nice infographic all that cardiac MRI can do. We can help patients with congenital heart disease, diagnose the anatomy, diagnose the severity of shunt. We can assess myocardial viability in patients who have had coronary artery disease. How much is scar? How much is muscle? What is salvageable? Because if patient has multivessel disease, which one do you stent and which one do you not stent? If we pass them, and I will tell you the one that is more than 50% transmurally scarred, which means that its likelihood of being recovered by revascularization is minimal, versus the one that is actually fully viable, and therefore you should go and stent that proportion, that artery. We can tell you where there's ischemia, myocarditis, deficient tensor imaging, valvular severity, etc. So I hope that I have convinced some of us that this is actually an excellent tool to have, an excellent tool to train in, and an excellent tool to offer our patient, because it actually transforms how we manage our patients, what we offer them, their outcomes. Thank you so much.
Thank you very much, Dr. Ofong. That's been a fantastic talk, condensed into just under an hour. That's gone from physics to physiology to biology to pathology, and it's been a really, really entertaining session. Now, there's a few questions in the Q&A box. If you still want to add more questions, just go to the Q&A box and do that. We'll try to take some of these questions. I promise that I wouldn't take too much of your Saturday, so we will try to keep the questions down to about 20 minutes. So we'll answer them really briefly. And if there's any that hasn't been answered by the end, we will carry it over to our next talk. So I'm going to start with the first question. So the first question that we've got here from Dr. Nelson, it says, he wants just a bit more explanation. He doesn't understand. He said, I am following how the spins are returning back to their natural habitat, but I don't really get the big picture implications of their return to their natural habitat. So if you could just maybe elaborate on that a bit.
Yes. So I think what I was trying to say, so if we remember that the YouTube video from John Hopkins will help a lot, because, they have put a nice infographic. But if you imagine those proton balls, they had an axis that was the arrow pointing up, right? And that's their longitudinal magnetization. So once you get a patient into the scanner, most of the protons will align in the axis of the scanner, which is that z-axis. But because they also have the ability to rock back and forth, this is the precession, that's their spin. This is their transverse magnetization. So whilst they are pointing this way, they're also doing this a bit. Now, and this they would do in alignment with the magnet's field. When you then superimpose another magnetic field through your RF pulse, the 90 degrees flip, it flips them. Now, it flips them all the way to the transverse so that almost all of them are now in this direction with none in your longitudinal. But once you take off the RF pulse, they start naturally returning back to that axis. Now, the time it takes for this to go back to 67% of this is your T1 time. Now, we also said that the reason why they can go from here back to here is that that acquired extra magnetic impulse that they got from the RF pulse, they lose it to the surrounding tissue. Now, if that tissue is like to like and not very dense, like fat cells that are just, just in their globules, but not a lot of solid matter, they're not surrounded by collagen or scar, they're just globules. They easily lose their magnetization and flip back. So fat has almost the shortest T1 time. Now, muscle, if it's surrounded by healthy muscle, will also lose its magnetization at a predictable time. But when it's surrounded by scar, it doesn't lose it very quickly, and therefore the T1 time becomes prolonged. And actually, prolonged T1 time is one of the cardinal diagnoses for diffuse interstitial fibrosis. So even if you now put them through late gadolinium enhancement, and I'll just answer the next question. The last question asked, what is LGE? Now, LGE is late gadolinium enhancement. It's just a description. It means that the muscle is enhanced at late gadolinium time imaging. And what's late gadolinium time imaging? When we give gadolinium, which is the contrast agent, we wait at least 10 minutes, some centers wait 15, and then scan. Now, in that time, healthy muscle would have absorbed the gadolinium and passed it into its veins, and therefore the muscle won't be white again. But if the muscle is unhealthy and has scar, because scar has expanded space, gadolinium gets, and I'll show some nice cartoons when we discuss it centrally. It goes into that scar tissue, but doesn't wash out quickly. So when we scan it in 10 minutes, we can still see gadolinium in the areas that have scar. And that is how we define the presence of fibrosis. So LGE is almost always equal to scar, but not, not absolutely. I'll explain further at the next sessions. So essentially, that prolonged T1 time, even if we don't see scar in that muscle, but we have categorical evidence that that T1 time, the time it takes for it to return, is prolonged, then we know that there's diffuse scar within the muscle. Yeah.
Thank you very much. That was very clear. The next question from Abdulrazak Zubair says, is there a simple way to differentiate T2 star from T2 weighted imaging?
Right. So T2 star, T2 time, T2 weighted are all related. The easy to start off with, T2 weighted is just that it's like the maps. Now, in the outcome studies, realize that because obviously, if you're measuring ROI, like just putting your ROI in small areas of the myocardium, there could be a lot of variability. So we realize that T1 time, the modality seems more robust than T2. So it's better to use a map because at a map level, you're now giving a general overview. You're now no longer going pixel by pixel, and that's more related to whether that correlates best with accuracy in predicting myocardial edema than just doing ROIs and saying, oh, over this ROI region of interest, what is my T2 time? Now, T2 star, if we go back, so remember, they were all aligned like this. We pushed them down with the pulse. But remember, we said that they have two magnetizations. They have the one that is z-axis, and they have the one that is precession like this. So when we push, give the RF pulse, and all your magnetization is a 90 degrees angle, is in the 90 degrees orientation, XY orientation, they still keep precessing once you take away that pulse, right? Now, so essentially what we say is that they are in phase when they are all aligned to that 90-degree transverse direction. You have all your protons in phase because they are all this way. But once you take off your RF pulse, they all start shifting because they are losing their magnetization. Plus, there's also inhomogeneity, like the magnetic field strength in every corner of the patient's body is not the same. So, some obviously are closer to the magnet, some are further from the magnet, and therefore how they experience is different. So the rate at which they come out of phase, so let's say this is phase, and out of phase is some are pointing this way, some are pointing this way, some are pointing that way. So if you give them time, everything that was pointing this way now varies like a spectrum. Some are pointing this way, that way, that way. And that's them going out of phase. So you then have, if I just go quickly back, if I still have control of this, I'll go quickly back to the diagram that showed it. Yes, so this one, oh gosh, let me guess. So this is them. You've applied your RF pulse. They are all in the XY direction. This is them in phase. But once you take off your RF pulse, they start pointing in different directions. They're dephasing. Now, remember that their strongest signal was when they were all in phase. Think of it as, imagine someone once described as, imagine that you're looking from a tall building on people downstairs that are running, wearing an orange jersey. If there's 20 people clustered together in one line, the orange is stronger. Once they start moving in different directions, the orange is no longer as strong from your bird's eye view because there's one here, one there. It's not a strong contrast. So once they start getting out of phase, the signal they generate is no longer strong. And then you start losing that signal. And that is what the amplitude of your signal starts fading away, fading away. Now, the total loss is actually your T2 star because it's a combination of what they lost by just going out of phase to the inhomogeneities in the field. But your ability to calculate the one they lost to just going out of phase is your T2 time. And the addition of what they lost to the inhomogeneity is now your T2. Like seeing both of them together is now your T2 star. So your T2 time is just the one they lose, the signal they lose by going out of phase till it completely fades away. But there's also the one they lose by the fact that they are not all experiencing the same field strength. So the inhomogeneities. And that's what imaging hemosiderosis actually pivots on, because obviously hemosiderosis is having iron, in the muscle in patients with. So actually, that inhomogeneity is now amplified because of the ion deposition, and therefore your T2 start time becomes a diagnostic marker of whether a patient has hemosiderosis or not. We'll get into it in detail.
Yeah, definitely. There's a lot more detail that you will go into, I'm sure. In the interest of time, I'm going to move to the next question. So it's a question about implants. It says, are implants less dangerous after they have been embedded for some time? I thought it was an absolute contraindication.
Yeah, thank you very much. Excellent question. So, when I started cardiology training years ago, it was almost an absolute contraindication, but it's certainly not an absolute contraindication. It's completely relative. Now, the absolute contraindication that still remains in cardiovascular MRI imaging is that you can't scan a patient who has a cardiac implant that is less than 6 weeks old, simply because you still have inflammation. And yes, you can move them because you're trying to assume worst case scenario that the magnetic field may still move the tip. Now, if they don't have scar tissue embedding them there, then, moving around the thin RV wall can be anything. Nobody wants to take that risk. And, the professor that did all the work at Barts basically use that 6-week cutoff. So all the guidelines still mention the 6-week cutoff. It's not an absolute contraindication because with the expansion of cardiac MRI imaging, even the manufacturers, Boston Scientific, Medtronic, etc., are now developing systems that are MRI safe, MRI conditional, MRI compatible. Plus, we're also knowing even how to scan what we call legacy devices, the older devices. So it's a combination of the right physician supervising the scan, the right physiologist. So patients with devices don't get scanned without a cardiac physiologist around, because like I said, during the talk, we have to change their setting to what, because essentially, if you're going to apply the results of research, then you have to make sure that your patient abides by all the parameters that were met in the research. What was the setting? What was it set at? What was the magnet strength? So whilst we can scan the patient in a 1.5 Tesla, it doesn't mean we can scan them in a 7 Tesla machine. So no, it's not an absolute contraindication currently.
Thank you very much. I agree with that. And in terms of the 6-week rule, we tend to use it for everything surgical. So even for people who've had hip replacements or
Exactly.
brain surgery with even if the device was MRI compatible, most people who've had surgery within 6 weeks, we tend to keep away from the magnet. And I think the same still applies to people who've had cardiac surgery as well. So there's a question around flow. So somebody mentioned that they didn't quite grasp the calculation of regurgitant fraction. Secondly, most importantly, it would be great to know which CMRI sequences are needed for which clinical question and cardiac conditions. I presume this will come in subsequent talks, but maybe you may want to touch a bit on this.
Exactly. So I think if I start from the last question, the sequences depend on the question we want to answer, which is why, we as physicians, we want to know the question you want answered so that we can then make sure that the right sequences are programmed into the protocol so that we get that. Because, again, we don't want a patient on a scanner breathing in and out and holding their breath for 90 minutes. It's just if you tell them to come back and have another one, they will not be keen. So you want to have a concise protocol that answers the clinical question directly. I think with flows, essentially the difference to calculate a regurgitant fraction, you need to, so the continuity equation from echocardiography basically is that the area times VTI at this valve has to be equal to the area, cross-sectional area times VTI at the next valve. So take, for example, cross-sectional area times VTI at the mitral valve has to be equal to cross-sectional area times VTI at the aortic valve, because it's the same column of blood that is going from one to another. So is it also on the right. So if we have a difference, then that difference must be going in the wrong direction, which is why we didn't catch it at the next point. Now, if we know that we have a regurgitant valve, then that's your regurgitant volume. Now, regurgitant fraction is basically that volume over the stroke volume times 100, which is your fraction. Now, when we're doing it on MRI, the fraction we use, the formula is still the same, but then how we calculate the flows is a bit more precise because we're basically putting cross-cut views, like, you get your plane through the aorta, and then you're basically assessing your flow through levels below the aorta, through the aortic valve and above. And then the software basically tracks, because obviously it sees the amount of sort of magnetic artifacts that goes through with the cardiac cycle, and then it can basically assess what the volume is. And then if we also have a regurgitation, it will also see it, and it will see the difference in volume, systole and diastole, and eventually it tracks a graph. And when we have that graph, you can see systole, you can see diastole, you can see where your regurgitation occurred, and it gives you a calculation. Now you want through plane views are this way, and then in plane are in alignment, because you need both to be able to calculate that volume. It's fair to say that a lot of what happens is backed up by supercomputing framework from both the scanner and the reporting software.
Absolutely, because there was a question as well. Somebody was asking about manually calculating volumes versus the machine. Obviously, there's a lot of new AI software and all sorts of things that help with the volumetrics and makes it a lot more accurate. So in the interest of time,
Exactly.
I'll just take one more question, and I promise you all the questions have been collated. Anybody's question that's not been answered, we have this running over 8 weeks, and you will get the opportunity. I bet you that some of the talks that are coming up, some of the excellent talks, will probably answer some of these questions as we go along. But I'm excited with the enthusiasm that people are showing with the questions. So unfortunately, because of time, we're going to have to take one more question, and the rest of it will be deferred. And we will also email you with some of the answers for some of the questions. Dr. Fong will do that, and we may be able to expatiate on some of them at other talks. So the last question is going to be this one. Are there any known cardiac pathologies that will make CMR impractical, maybe from the functional or structural behavior of the heart in such pathologies?
Yeah, I think my shared window has probably come to an end. I'm not actually aware of any. Now, the only one I can think of is what I had mentioned in the talk, which is vegetations. Vegetations are both hypermobile and tiny, that we don't really see, except it's a big clump of inflammatory material on the valve or on the prosthetic, device or leads. We don't see it as well on MRI as we see on cardiac CT. But there's actually no cardiovascular pathology that makes CMR impractical. No, I'm not aware of that.
Okay, that is fine. On that note, I want to thank Dr. Fong for a fantastic, very stimulating lecture. And for the audience as well, this is one of the first talks I've been to where people have hung on for 1.5 hours. The numbers haven't dwindled. And it shows the interest that we have with some of the topics that are going to be discussed. So I'm going to share my slide just to give you a preview of what's coming, and also in date order, what you should expect. If you just give me a second, I will share my slide again. There you go. So the next lecture is going to be so the next lecture is also going to be quite interesting, how to set up a CMR program on existing infrastructure, and that's on the 18th of April, on Saturday. So same time, Saturday, 18th of April, we'll get a lecture from Harrison Adulua, who's a CMR radiographer, an expert, and he'll talk you through how to set up a program. For those of you who are looking to set up programs, that will be a really interesting lecture for you to be able to pick up what you need. Those of you who have magnets that aren't doing it already, you may be able to see where the gaps are and ask a few questions. For the radiographers in the group, that would really be an opportunity for you to explore some of the things that have been talked about today. So on that note, I'd like to thank you very much for taking your time to be with us this Saturday and for listening, being quite an interactive audience. And it's my hope that you can let others know that these sessions are going on. They're free. And like I said earlier, try and complete the survey at the end of it, so that you can be able to get an attendance certificate. I don't think anything this comprehensive has been run in Nigeria before. And it might interest you to know that we've got participants attending from places as far away as the Middle East and Nepal. So this is an international audience. So it's been a good opportunity to know about the topic of CMR, which is important to the management of patients in the cardiac space. So thank you very much for your attention, and we look forward to the next session next Saturday. Enjoy the rest of your weekend.
Thank you, everyone.